But you can, whenever a case scenario is given, I always advise the students to first point out what are all the challenges in the management of these cases. Okay? So challenges in the management of include patient position depending upon the surgical approach. That is the first and foremost thing you have to discuss with the surgeon. Intraoperative electromyographic monitoring, whether it is required or whether he is planning to do that. Most of the surgeons nowadays, they do that. And hemodynamic monitoring to prevent air embolism, and management of surgical stimuli causing bradycardia, and post-operative assessment of neurological function. So patient should be immediately alert after the surgery, and management of intracranial pressure. So these are all the challenges that you face in this particular case. And the anesthesia technique, usually a balanced anesthetic technique combined with a volatile and intravenous infusion of propofol is used. And neuromuscular blocking agents have to be used judiciously, especially if the surgeon wants to do a neuromonitoring of the facial nerve and other nerves. And close monitoring of arterial pressure is very crucial with the target MAP of 70 to 90, so that the brain perfusion or the cerebral perfusion pressure is well maintained. And it will also help in preventing a air embolism, because hypotension causes more drawing of air in the open sinuses because of the low pressure, whereas a normal pressure will prevent air entrainment. And intraoperative EMG monitoring of facial nerve is performed by the surgeon. So you have to preserve the integrity of the nerve, stability of the nerve. Now, coming to the patient position, it depends on the surgical approach. And the surgical approaches are fossa craniotomy or translabyrinth craniotomy or suboccipital or retro mastoid approach, which is called the posterior cranial fossa approach. So, surgeon can go through any of these for approaching this particular lesion. And this is the classical approach majority of the times they use, which is called the sitting position for suboccipital craniotomy approach. So patient is first induced in the supine position, and then there is a special table available which will raise the back to almost sitting position, and Mayfield clamps will be applied to position the head in a steady state. And the importance of this positioning is you have to gradually increase the position, checking the BP so that there is no sudden hypotension in this particular thing. And you can see the leg compression will be available both to prevent the venous air embolism as well as to prevent the hypotension that is happening. So these compression stockings and leg mechanism should be applied well before you start the positioning of the patient. And the pressure points all have to be taken care of, especially at the elbow and wrist and the knee, etc. have to be taken care of. And this is the incision for translabyrinthine approach where the exposure is done. And this is the middle cranial fossa approach, which is done on the temporal region. And this is the exposure that will be done by this approach. Now, the second important thing, what are the common complaints coming to the history of this patient? They will have a sensory neural hearing loss. And they will have tinnitus, they may have disequilibrium or unsteady gait, they may have facial trigeminal nerve dysfunction and brainstem pressure features, dysfunction of the cranial nerves which are close by. The points we have to look for during evaluation of cerebellar and cranial nerve function have to be documented so that you see whether it has happened hydrogenically during surgery or it was present even before that, especially from medical legal point of view. And any signs of raised ICP, what is the hydration? Because patients with raised ICP, as he described, who have repeated vomiting, may be dehydrated and have electrolyte imbalance. So we have to assess the hydration and electrolytes. and discuss with the surgeon regarding the position for surgery and the need for neuromonitoring, evaluate airway and plan air management, and any plan for nerve monitoring also have to be included. What are the monitors to be used in this surgery? All routine monitors plus arterial PP, invasive arterial line, CVP, and the electromonitoring for monitoring also has to be included. For detecting air embolism in the sitting posture, the monitors that you can use are precordial Doppler, transesophageal echo Doppler, or esophageal stethoscope also will be able to help you to hear the alveolar murmur that can happen. And the end tidal nitrogen measurement. This is another important because there is air will be coming out from the absorbed thing. So nitrogen levels will go. And the neuromonitors that are used are brainstem auditory evoked potential. Sometimes they use EEG also. Then you can use somatosensory evoked potential and the EMG monitoring for transcranial. The goals of anesthetic management are prevent ICP raise if the patient already has features of raised ICP by careful induction and use of mannitol or dexamethasone and diuretics if necessary. Of course, raised sitting posture itself will help in somehow reducing the ICP. But in your anxiety to reduce ICP, you should not jeopardize the cerebral perfusion. And hemodynamic stability is very important. To enable neuromonitoring, early detection of any complications like air embolism is very important. Intraoperative complications that can happen, especially if they are doing microscopic surgery with microscopic magnification. The cranial nerves can be included, and bleeding can happen, brain edema can happen, brain herniation can happen, and also cardiac arrhythmias and air embolism can happen. Post-op complications after microsurgery are bleeding, obstruction, CSF leak, meningitis, hemoencephalus, macroglasia. This is one of the important complications that can produce upper airway obstruction because of the positioning. The pharynx and the tongue, they all swell up, and without noticing that, if you extubate, that may cause a severe upper airway obstruction and produce hypoxemia. And any injury to the brainstem can result in quadriplegia also. So, power in the, that is the reason why we want the patient to be awake quickly to check whether the motor power in all the limbs are very important. And that is the reason why I mentioned about the importance of early recovery to assess the neurological status post-operatively. Okay, so that is all about the